Hello everyone. We'll be going through a second part of neonatology. From this part onwards, we'll be going into a bit more detailed view so that you can have a better understanding of the topic as well as the subject, and you can be better prepared for answering the questions coming your way.
So, neonatal resuscitation. As an introduction, this is a very important topic from which many questions are asked. So, you need to learn the key concepts in detail. Okay. The successful transition from the intrauterine to extrauterine life is dependent on significant physiological changes that occur at birth. And although most newborns successfully make this transition at delivery without requiring any special assistance, a small but significant number of newborns do require some form of assisted support or some kind of resuscitation in the delivery room. Okay. The order of priority of resuscitation in newborns is TABC. Okay, that is first comes temperature, then comes the respiration, that is the airway, then comes breathing, and then comes circulation. Okay. The order in adults you have to remember is circulation is the first priority. Okay. So why is respiration the first priority? That we'll see in the next slide. Okay. So listen carefully to the next slide. So for a deeper and mandatory understanding of newborn resuscitation, we need to know what happens in the adults. Okay. Most often, an adult cardiac arrest is a complication of CAD, that is coronary artery disease. Okay. It is caused by sudden arrhythmia that prevents the heart from effectively circulating blood to the system. Okay. And as the blood flow to the brain decreases, the adult victim loses consciousness and stops breathing. And at the time of arrest, the adult victim's blood CO2 and blood oxygen content is relatively normal. Okay. And the lungs remain filled with air. And during adult resuscitation, the chest compressions maintain circulation until some form of support, that is either in the form of an electrical defibrillation or medications, restore the heart's function. Okay. That is not the case with the newborn. Okay. And that's what we're going to see. Okay. So listen carefully to the next slides. Hence, this is the reason why CAB is the order for resuscitation in adults. Now we have to know the exact reason why newborns require a different approach than the adults. Okay, why respiration is the priority. Okay, so before birth, fetal respiratory function is performed by the placenta instead of the fetal lungs. Okay, so when the placenta is functioning normally, it means that it transfers oxygenated blood from the mother to the fetus and carries CO2 away from the fetus to the mother. Okay, a healthy fetus makes breathing movements which are important for normal lung growth. Okay, and when placental respiration fails, the fetus receives an insufficient supply of oxygen and carbon dioxide cannot be removed. Okay, so as a result, the acid levels increases in the fetal blood as cells attempt to function without oxygen. Okay, and also because carbon dioxide also accumulates. Okay, and at this point, if we do a non-stress test or an NST, the fetal monitoring may show a decrease in activity, loss of heart rate variability, and heart rate decelerations. Okay, and if the placental respiratory failure persists, the fetus will make a series of reflexive gasps, which can be followed by bradycardia and apnea. And if the fetus is born in uh, the initial phase or early phase of respiratory failure, tactile stimulation may be sufficient to initiate a spontaneous breathing and recovery from the failure. But if the fetus is born in a later phase of respiratory failure, the newborn will require some form of assisted ventilation to recover. Okay, and the most severely affected newborns only, just remember, the most severely affected newborns only may require chest compressions and drugs such as adrenaline. Okay, And at the time of birth, the issue is that you may not know if the baby is in an early respiratory failure or a late respiratory failure. Okay, so there comes the significance of following the neonatal resuscitation protocol, which we will learn in the subsequent slides. Okay, and and we have to know as for a fact that unlike adults, newborns in contrast, they have a healthy heart. Okay, and when a newborn requires resuscitation, it is usually because respiratory failure interferes with the oxygen and CO2 gas, the exchange. Okay, the exchange. I'm hoping you understood. Okay, and so once again, to drive home the point, ventilation of the newborn's lungs is the single most important and effective step in neonatal resuscitation. So we'll be going into fetal circulation next. Okay, this is for knowing what happens during the transition from fetal to neonatal circulation. Okay, understanding the basic physiology of the cardiorespiratory transition from intrauterine to extrauterine life will help you to understand the steps of the neonatal resuscitation protocol. So this is the fetal circulation diagram. I'll try to make a pointer. This is small, but this is the only thing I have. Okay, so this is this fetal circulation. As you all might be knowing, before birth, the fetal lungs, okay, the part which I'm highlighting or at least trying to highlight, the fetal lungs are filled with fluid and not air, as they do not participate in gas exchange. Okay, so all of the oxygen used by the fetus is supplied from the mother's blood by diffusion across the placenta. Okay, the oxygenated fetal blood leaves the placenta. Okay, the oxygenated fetal blood, the red vessel, the reddishly shaded vessel, as I'm trying to point out, leaves the placenta through the umbilical vein, that is the reddish vessel, and it goes into the right atrium. Okay, and the blood vessels in the fetal lungs, okay, that is the pulmonary vessels, they are tightly constricted and very little blood flows into them. Okay, instead, most of the oxygenated blood returning to the fetus from the placenta via the umbilical vein flows through the foraminoveil. Okay, this yellow arrow that I'm trying to point in, the flows through the foraminoveil or the ductus arteriosus. Okay, this part, okay, ductus arteriosus, and as a result they bypass the lungs, that is the oxygenated blood bypasses the fetal lungs. Okay, and because blood flows directly from the right side of the heart to the left side without entering the lungs, it is called a right to left shunt condition. Okay, and inside the uterus, this right to left shunt, it actually helps the fetus to have its richly oxygenated blood to flow directly into the fetal brain and fetal heart. Okay, so actually that is a protective mechanism. Okay, which has to be there for the fetal growth, fetal brain and fetal heart growth, and for proper oxygenation of the fetal system in the intrauterine life. Okay. So after baby's birth, a series of events, they culminate in a successful transition from fetal to neonatal circulation. Okay, as the baby cries and takes deep breaths, fluid is absorbed from the alveoli. Okay, or the air sacs. Okay, and the lungs fill with air. Okay, as you can see from these four alveoli progressively are replaced or absorbed of fluid, and air is gradually filling the alveolar sacs up. Okay, okay. So then what happens? Then this happens. Okay, there is vasoconstriction. Okay, initially the blood vessels or pulmonary vessels are constricted when the alveoli has fluid inside. Okay, now after the baby has taken his first few breaths and cries, the vessels dilate. Okay, the vessels dilate and the air can flow into the alveoli where oxygen will be absorbed and carbon dioxide will be removed. Okay, by the process of CO2 and oxygen exchange. Okay, diffusion, gas exchange happens in the alveoli. Okay, via this mechanism, that constriction is relieved by the presence and incoming of air. So this is a transitional circulation pathway. Okay, this is not a fully mature newborn circulation, and this is not a fetal circulation. This is the process that happens in between those two. Okay, the oxygenated blood. Okay, this is the baby's lungs that is gradually being filled with normal air. Okay, so the oxygenated blood which now returns from the baby's lungs. Okay, baby's lungs, that is these reddish things. Okay, these reddish parts of the diagram, they fill the baby's heart. They fill the baby's heart and ensure that the heart and brain will receive adequate blood flow once the umbilical cord is clamped. Okay, so what happens when you clamp the cord? Clamping the umbilical cord, increases it the baby's systemic blood pressure, decreasing the tendency for blood to bypass the baby's lungs. Okay, okay. I hope you understood. Okay. And although the initial steps of transition occur within a few minutes of birth, the entire process may not be complete for few hours or days. Okay. For example, it may take up to 10 minutes for a healthy newborn or a healthy term newborn to achieve an oxygen saturation of greater than 90%. Okay. But it may take several hours for a fluid in the lungs to be completely absorbed and the complete relaxation of pulmonary blood vessels, which also occurs gradually over several months. Okay. Here the one point that I mentioned right now, it may take several hours for the fluid in the lungs to be completely reabsorbed. Okay. That point will be very valid when we learn a few conditions of respiratory distress in the newborn in the coming portions. Okay. So keep that in mind. Okay. And although we anticipate a resuscitation for every delivery that we attend to, there are certain factors which make a delivery a high risk delivery. Okay. So the antepartum conditions which causes that are advanced maternal age or age less than 16 years for a pregnant mother, poor socioeconomic status, detrimental habits such as smoking, drinking, drug abuse, maternal medical conditions such as diabetes mellitus, which is very important, and hypertension, CKD, lung diseases, kidney diseases, any chronic diseases, hematological disorders in the mother, and obstetric conditions such as prior stillbirth, prior birth of a high risk mm, baby, bad obstetric history, then antepartum hemorrhage, then premature rupture of membranes, sepsis during pregnancy, and of course placental anomalies such as placenta previa and the polyhydramnios, oligohydramnios, and all. Okay. Now coming to the fetal conditions which are associated with the high risk delivery, it is of course first and foremost is prematurity, post maturity also, intrauterine growth restriction, macrosomia, multiple gestation, and of course during birth complications of maternal medical disease can happen. Preterm labor, prolapse cord, uteroplacental bleeding, anomalies of presentation. Then there is sepsis such as chorioamnionitis, instrumental delivery, narcotics administered for mothers within hours prior to birth, CS delivery for fetal compromise. Okay, such things are associated with a high risk delivery where neonatal resuscitation is much more probable. Now, these are the neonatal resuscitation supplies and equipment that we need should a need for resuscitation come around. Okay, the warming and transport equipment and suction equipment and monitoring equipment. Okay, these three equipments we use even if there is no need for a most often we use even if there is no need for a proper resuscitation. There needs to be a preheated warmer with warm blankets, baby hat if necessary, or rather if available, a plastic bag or wrap for very preterm infants less than 32 weeks of gestation for preventing hypothermia, and a transport incubator also, especially for preterms only. Suction equipment such as either a blunt suction or mechanical suction. Mechanical suction is usually preferred and it is now widely available in most centers. Okay. And a meconium aspirator, if present, it is good. And a monitoring equipment such as stethoscope, which is mandatory, And a cardiac monitor and pulse oximeter, if present, it is very good. Okay. Next is a source of free flowing oxygen blender. This is not available in most of the centers because we are essentially a resource poor country, and if available, oxygen blender is very much high above the list, and face mask with appropriate sizing is mandatory, and a positive pressure delivery device such as a T-piece resuscitator or a self-inflating ambu bag and an oropharyngeal airway. Intubation equipment has to be checked before every delivery. Laryngoscope blades of different sizes, handle and stillet. Endotracheal tube sizes 2.5, 3 and 3.5 usually, and laryngeal mask airway also. Vascular access equipment such as umbilical venous catheterization tray and supplies, and then peripheral intravenous catheters with securing supplies, needles and syringes, and medications such as IV epinephrine, novel saline, 10% dextrose, and sometimes naloxone also. So these are the different ET tube sizes which are required for neonatal resuscitation. Size 2.5 to 3.5 is commonly available, and that is usually required only. And size 2.5 is usually for gestation ages less than 28 or weight less than 1000 grams or 1 kg. Size 3 and above, size 3, 28 to 34 weeks of gestation and weight 1 to 2 kg. And 3.5 size is used from 34 to 38, that is term. That is 2 to 3 kg. And if it is a macrosomia child, or the child weighs more than 3 to 3.5 kg, usually a size of 3.5 to 4 will do. Okay. And laryngoscope size, number 0 laryngoscope blade is used for preterm infants, and number 1 size is used for term infants. Okay. There is a 00 size also which is used for extremely preterm infants. Okay. And one more characteristic of laryngoscope blades that are used for neonatal intubation or resuscitation is that they are straight blades. Okay. The adult blades, and for older children we use curved blades, whereas for neonatal resuscitation it is always a straight blade. Now we'll go into the neonatal resuscitation protocol proper. Okay, it is known as the NRP. Okay, the NRP algorithm, it describes the steps that you will follow to evaluate and resuscitate the newborn. It is divided into 5 blocks beginning with birth and the initial assessment. Throughout the algorithm, you will see that there is hexagonal boxes and rectangular boxes. Okay, the hexagonal boxes, they indicate uh, the assessments we have to do, and the rectangular boxes, they indicate the actions that may be required. Now we'll go into the neonatal resuscitation protocol proper. Okay. Antenatal team counseling, team debriefing, and equipment check has to be done. Then, as the order of resuscitation is TABC. Okay, remember that. Okay. Initial assessment, you have to check for cry and whether the baby is born as term baby and how the tone is. Okay. If all these are normal, baby can be shifted to the mother side. Okay. After routine steps of warmth, drying, stimulating, and position of airway, clearing of secretions if at all any are present. Okay. Then we shift to other side. Okay. Even if there is no cry initially, the routine care steps has to be done first. Okay, that is the most important thing. Okay, even if a baby is coming to you without crying first, still you have to follow the first step, that is warm, maintaining normal temperature and airway positioning and clearing of secretions. Okay, and still if there is no cry, assess the heart rate and respiratory effort. Okay, in significant hypoxia, decrease in heart rate is the first physiological change that will happen. Okay. And suppose if the heart rate is more than 100 with labored respiration and cyanosis, oxygen supplementation via an oxygen hood or a CPAP delivery machine will be necessary. Okay. And if the heart rate is less than 100 with the child not breathing or the baby not breathing, you have to initiate positive pressure ventilation via bag and mask or via ET tube and intubation. Okay. Then, if at all you have to do resuscitation and you have to give CPAP or you have to give bag and mask ventilation, the head position should be proper. Okay, this This is a correct position. I hope you can see my pointer, the reddish marking. Okay, this is the correct exact position. Okay, it is known as a sniffing dog position. Okay, not too much flexion, not too much extension. Okay, the second picture shows us the excessively flexed posture, which is incorrect, and the third picture shows us the excessively extended, that is hyper extended position, that is also not correct. Okay, the resulting, the correct position, if we put the child in, there will be an alignment of the posterior pharynx, larynx and trachea. Okay, which helps in an unrestricted air entry. Okay, and so when you have to give positive pressure ventilation, first line is definitely bag and mask ventilation. Okay, it is known as non-invasive positive pressure ventilation. Okay, the usual bags that we use, they range from a volume of 240 to 750 ml. Okay, that much volume of air is there in the bag. Okay, and there is a reservoir bag which increases the concentration of oxygen that is delivered. Okay, when it's connected to a port. Okay, and how we should do, the technique is extremely important. Okay, wrongly performed resuscitation is much more dangerous than a baby not receiving resuscitation at all. Okay, most often. Okay, and how should we do? The mask should be appropriately sized. Different size masks are there which we should check prior to the delivery. Okay, prior to every delivery we should check. Okay, the mask should cover both the nose and the mouth. Okay, and the response after bag and mask ventilation should be increased heart rate, improvement in baby's color. Okay, if there is no response, you have to check the ventilation corrective steps. Okay, that is known by the acronym MR-SOPA. Okay, what is MR-SOPA? As per the protocol, you have initiated the bag and mask ventilation. Still, you are not seeing any positive response. Then, instead of going to the next step, you are supposed to check for any corrective steps you have to do in the bag and mask ventilation, such as mask readjustment, repositioning of the head, suctioning of the child's airway, opening of child's mouth, increasing your positive pressure ventilation pressure, and planning for any other alternative airway. Okay, so the short form, the acronym for this is MR-SOPA. Okay, so once again, let's go through the position and the ideal way you have to do. The hand. Okay, the rescuer's hand is positioned so that the little finger, the ring finger, and the middle finger, okay, they are spread over the mandible from the angle of jaw forward towards the chin in the configuration of the letter E. Okay, E. Here it is written E. Okay, and the jaw is then lifted, pulling the face into the mask. Okay, jaw is lifted, pulling the face into the mask. Okay, the thumb and the forefinger, they are placed over the mask in the shape of the letter C. Okay, I hope you can see this. Okay, and the mask is squeezed onto the face and a seal is formed between the mask and the face. Okay, I hope you got that. Okay, that E and C position. Okay, and at what rate we have to give? 40 to 60 breaths per minute. Okay, which is the normal range of respiration for a newborn. Okay, okay, and the higher pressure has to be given for the first breath, and subsequent breaths lower pressures can be given. Okay, the fraction of inside oxygen or FiO2 is 30% for preterm, which can be titrated according to the saturation values. And for a term baby's resuscitation, first we always prefer room air resuscitation, that is plain room air, 21% oxygen. Okay, and only one condition is there as the absolute contraindication for bag and mask ventilation, that is CDH. CDH means congenital diaphragmatic hernia. Okay, here if we do bagging, the CO2 can enter the intestine and can dilate. Okay, which can further compress the lungs and can worsen the already existing respiratory distress. Okay, so suppose even after the bag and mask ventilation, the heart rate is still less than 100 per minute. Then what do we do? Then we check for the chest movements, we correct ventilate to corrective measures, and we do then, which we already mentioned. And still, if the heart rate is less than 60 per minute, we have to go for chest compressions first. Okay, okay. So chest compressions you have to do in the ratio of 3:1. Okay. For the 3:1. That is 90 chest compressions plus 30 ventilations in a single minute. Okay. Okay. And afterwards, if you are already doing chest compression, it is always better to into. So the ET tube sizes and appropriate gestation age and weight categorization we already mentioned. But a few points that you should know is that straight blade laryngoscope is used, and we always prefer ET tubes that are not cuffed. Okay, uncuffed ET tubes are preferred for newborns, and the inner diameter of the tube is always the size mentioned. Okay, this 2.5 size and 3.5 size we indicate the inner diameter of the tube. Okay, and the length of insertion, it is roughly 6 plus the weight of the baby. Okay, suppose it is a 3 kg baby, the length of insertion is up to the marking 9. Okay, and the best way to confirm ETT position is ETCO2 capnography. Okay. Okay, so the first method of chest compression. Okay, there are two methods. The first method is the two-finger technique, which is typically used when there is only a single rescuer for resuscitation. Okay, you need to follow this line. Okay, I hope you can see the pointer. This is the nipples. Okay, these are the nipples of the baby, and this is the intermammary line. Okay, or you can also call it as a nipple line. Okay, just below the nipple line and just above the syphilis sternum. Okay, this area where I'm pointing right now is where you should put all the pressure into. Okay, chest compressions may be performed with two fingers placed on the sternum as shown in this figure just below the nipples. Okay, this picture shows the site of compressions, and when compressions are performed, the two fingers used should be perpendicular to the chest and they should be straight. And now this is the two thumb technique when there are multiple rescuers available. Okay, there also the nipple line is the same. The position of pressure, the position where you have to give pressure via compression is also the same. Okay, the thorax is encircled with the hands. Okay, and cardiac compressions are performed by both the thumbs. Okay, the compression side is approximately one finger's breadth below the nipple line. Okay, the area of the xiphoid process should be avoided so as to not to cause injury to the liver, spleen, or the stomach. And so, if the heart rate is still less than 60 per minute, even after giving chest compression, adrenaline has to be given. Okay, it has to be given either intravenously via the umbilical venous catheter or intraosseously or even intratracheally. Okay, if you are giving via the IV or IO route, the dose is 0.2 ml per kg of 1 is to 10,000 solution. Okay, that is a recent NRP change which we will go through later. And if there is no response even after giving adrenaline, volume expansion with IV fluids has to be tried. Okay. And still if there is persistently bradycardia is there, consider pneumothorax also. Okay. And then these are the medications which we use in neonatal resuscitation: epinephrine, isotonic saline, and very rarely sodium bicarbonate also. Okay, what does adrenaline do or epinephrine do? It increases the cardiac output by increasing the heart rate and myocardial contractility, also increases BP by causing peripheral vasoconstriction. Indication is bradycardia less than 60 per minute despite adequate ventilation and chest compression. Okay, that is the catch there. Okay, and the dose is actually 0.1 to 0.3 ml per kg intravenously of 1 is to 10,000 solution. But now with the recent NRP, the 2020 neonatal resuscitation protocol, there is a change for convenience that is taken as a fixed value of 0.2 ml per kg of 1 is to 10,000 solution. Okay. And a few facts which is mandatory. The first 1 minute of neonatal resuscitation is known as the golden minute. Okay. And the first 30 seconds it is PPV to initiation of chest compressions, and the next 30 seconds is chest compression to initiation of adrenaline. Okay, so the whole process up until adrenaline you have to finish within 2 minutes. 2 minutes. Okay, that much quick and that much objective you have to be. And withhold resuscitation after 20 minutes of all steps. Okay, that again is a new change. Okay, that again is a new change. Earlier it was 10 minutes. And these are the new changes. Now the new edition is NRP 2020, that is the 8th edition. Okay. Okay, the changes you need to know from your level are that the dosage changes of adrenaline. Okay, earlier it was a range dose, that is 0.01 to 0.03 mg per kg, or rather 0.1 to 0.3 ml per kg. Now for convenience purpose it has been changed to 0.02 mg per kg or 0.2 ml per kg. Okay, and also the time frame cut off for stopping resuscitation has been hiked to 20 minutes. Okay, officially. Okay, in practice the cutoff was put as 20 minutes even long back, but now it has come to as an official change. Okay, so what is Apgar score? Apgar score, okay, first of all you need to know that it is just a scoring system, okay, to assess how well the baby is responding to resuscitative efforts. Okay, it is not used as a guide for resuscitation. It is just to assess the baby's response to resuscitation if it is performed. Okay. A is for appearance, P is for pulse, G is for grimace. What is grimace? Grimace is actually means response to a catheter being put into a baby's nose. Okay. And activity means baby's tone or baby's posture. Okay. Those terms can be misleading. Okay. Appearance, pulse, grimace, activity, and respiration. Okay. And each are given a score from 0 to 2. Okay. A 7 to 10 score is normal, and a score in the range of 0 to 6 means child is in distress. Okay. And an extended Apgar score can be done every 5 minutes up to 20 minutes if the first 5-minute Apgar score is less than 7. And next possible scenario is the baby wants the meconium stained liquor. Here also you have to do the routine steps. And if it is a vigorous baby, you follow the normal steps. And if it is a non-vigorous baby, early positive pressure ventilation is ideal, but no intratracheal suctioning. Okay. And what do you mean by vigorous baby? Vigorous baby is a baby who is having a heart rate of more than 100 and a baby with a good tone. Okay, that is a vigorous baby. Then, levels of newborn care. Okay, this is another topic which you need to know. There are two systems you have to know. First is the AAP classification, that is American Academy of Pediatrics classification, by which it is divided into 4 levels. Level 1 is a basic unit which consists of a normal newborn care where babies are stabilized and they are referred if sick. Okay. And level 2 is a setup which cares for a moderately sick newborn where facilities of CPAP and ventilator facilities for a brief period are available. Level 3 is the next higher step level unit where critically ill neonates are cared for and they have a full range of respiratory support. Okay. Even prolonged ventilation services are available. Level 4 is a health facility where a full range of even advanced subspecialties such as neonatal cardiology support, pediatric surgery support, and all other subspecialty supports are available round the clock. Okay, that is a level 4 facility. And then coming to our Indian scenario, there has been a classification put forward by Minister of Health and Family Welfare, okay, which was ideally put forward in 2015 onwards. Okay, first basic unit is newborn care corner, okay, which is mandatory at all birthing centers where a well baby is cared for and referred and sick and at-risk newborns are referred. Okay. Next level, next higher up level is newborn stabilization units or NBSU, where NBCC services are there, plus sick newborn care to babies who weigh more than 1.8 kg are present. And special newborn care units or SNCUs where facilities of NBCC and NBSU plus babies who weigh less than 1.8 kg are cared for with limited ventilation facilities also. Next topic is care of normal newborn at birth. Okay, this slide is regarding at birth and subsequently we will see in the next slides. Okay. 5 cleans has to be maintained strictly. Okay, that is mandatory. Okay, universally mandatory. The 5 cleans which need to be observed to prevent sepsis at birth: clean hands, clean surface, clean blade, clean clamp, and clean cord. Okay, the personnel who are attending the delivery must exercise all the universal or standard precautions in all cases. Okay, all fluid from the mother and the baby should be treated as potentially infectious. Okay, gloves, masks, and gowns should be worn when resuscitating the newborn. The protective eyewear or face shields should be worn during procedures that are likely to generate droplets, okay, such as CPAP, okay, or ventilation, okay, or drops of blood or other bodily fluids, okay. I hope that's clear. Okay. And next, how do you care for a newborn at birth? Delayed cord clamping is also there. Okay, why? To allow an additional amount of blood transfer which needs to be delayed for at least 30 seconds. Okay, improved hematological status and improved iron status are the few benefits. Okay, one among the many benefits in term babies and reduced incidence of intraventricular hemorrhage and better hemodynamic stability in key beneficial factors in babies who are born preterm. Okay, and the main point here you should know is that in case of emergency situations such as birth asphyxia, this cord clamping should not be delayed. Okay, it should be immediately cut and baby should be brought for resuscitation. Okay, that is the point. Next main thing you have to be careful at birth is hypothermia prevention. Okay, the delivery room temperature, it has to be maintained at minimum of 25 degrees Celsius and there should be no free draft of air in the delivery room. Okay, and there should be pre-warmed sterile linen sheets and skin to skin contact between baby and mother must be ensured, provided that the baby is not sick or needing resuscitation. Okay, immediately after birth the newborn is at the highest risk of hypothermia. Okay, this early hypothermia may have a detrimental effect on the baby's health. Okay, special care should be taken to prevent and manage hypothermia. The infant should be dried thoroughly, including the head and the face, and any wet linen should not be allowed to remain in contact with the infant. Okay, the infant may be placed on the mother's abdomen immediately after the birth for early skin to skin contact. Okay, this will not only promote and maintain the newborn's temperature, but it will also promote early breastfeeding and decreases the pain and bleeding in the mother also. Okay, so that practice is actually important. Okay, that as doctors who are attending the delivery, we should make sure that it is done. Okay, provided that the baby is not sick or needing resuscitation. Okay, next is cleaning of the baby. Uh, Gently it has to be done. Blood and excessive fluid or excessive moisture has to be wiped off. Okay, meconium also, if it is present, has to be wiped off. But the vernix caseosa, it protects the skin and it will go away on its own. Okay, that need not be specifically wiped off and cleaned. Okay, the whitish cheesy greasy material which is obvious in this picture, it will go away on its own. Okay. Clamping of the cord, it should be done 2 to 3 centimeters away from the baby's abdomen, and the clamped cord stump should be kept away from the baby's genitals. Okay, that is just above the diaper or nappy if it is being put. Okay, it should be kept away from the genitals for preventing the ascendancy of infections. Okay, and also to avoid traction and pulling and possible bleeding. Okay, then uh, The ID band has to be kept. That is mandatory. Make sure that it is done. Okay, that is very mandatory. Okay, mother's name, baby's medical records number, baby's gender, weight, time of birth and date of birth are the necessary details which has to be present in the ID band. So in the first few hours after birth, baby's weight has to be recorded. A thorough examination has to be carried out for checking of injuries or malformations. Anal patency has to be checked. Initiation of breastfeeding has to be done within the first hour of life, especially if it's a normal delivery baby. If it's a cesarean section baby, still within the first hour of life or within the first 2 hours of life, if possible, it should be done. First feed should be assisted feeds, and then vitamin K has to be given. 0.5 milligram is a dose for less than 1 kilogram babies, and 1 milligram is a dose for babies who weigh more than 1 kg. Okay. Vitamin K1 and vitamin K2 are the two preparations that are available. K1 is more preferred. Why? Because vitamin K3 can cause hemolysis in G6PD deficient babies. Okay, it is given in the intramuscular route, the site being anterolateral thigh. It is given to prevent hemorrhagic disease in newborn. Okay, and next is communication with family, gender, the baby's weight, well-being, and baby's feeding, whether it has been done or not, has to be conveyed to the relatives. Okay, and roaming in is indicated unless there is some other disease process or some other issue with the baby or mother is there. Okay, which prevents the roaming in. Okay, roaming in helps with mother and baby bonding. Okay, so once again, to re-emphasize some points, weighing machine with at least 10 gram sensitivity should be used. Electronic weighing machines are ideal, and zeroing of the machine should be performed. Okay, the baby should be thoroughly examined at birth from head to toe, and the findings should be recorded in neonatal record sheet. Examine the midline structures for malformations such as for cleft lip, neck masses, cleft palate, chest abnormalities, then conditions such as omphaloceal, meningocele, cloacal abnormality and all. Okay, special attention should be given to identify and occupy the anal opening. Okay. Okay, and then vitamin K3 can be given if the K1 preparation is not available. Okay, the only risk being babies being G6PD deficient. Some babies being G6PD deficient, those babies can have a hemolysis. Okay, and the communication to the baby's bystanders should be clear, crisp, and should be carried out in a confident manner. Okay. Then beyond the first few hours, cord care has to be done. Exclusive breastfeeding, lactation or nurse counsel, lactation nurse or lactation counsel will be extremely helpful in today's circumstances. And sleep positions, be very careful because sudden infant death syndrome has to be reported in babies who have been slept in a prone position. Okay, so supine position or babies lying on their back is the preferred position. And harmful traditional practices such as kajal, surma, putting oil into the ear, putting cow dung on the cord, and giving pre-lacteal feeds, especially in South Indian parts of India. Okay, South Indian parts of the nation. Okay, pre-lacteal feeds are usually given. All these are harmful traditional practices, and they should be strictly be discouraged. Next, we'll go through a few benign neonatal issues and those of which are major concern to parents, but those which are physiological. First is weight loss, which happens to the tune of 8 to 10% in term newborns, which is usually regained by 7 to 10 days. And thereafter, subsequently, the rate of weight gain is 20 to 30 grams per day. Okay. Next is crying during micturition, which happens due to the sensation of a full bladder, which is unfamiliar to them. How to differentiate this from a probable UTI? In a physiological cry at the initial stage of micturition or just as the act of micturition begins, the child will be calm and quiet. Okay, the cry will disappear. But if the baby keeps on crying during the passage of urine, that is a probable UTI. And regarding bathing, if a baby is more than 2.5 kg, he can be bathed after discharge from hospital. And for prevention of hypothermia, the head, since it constitutes the maximum body surface area of a newborn, while bathing, the head should be washed last and it should be dried first. Okay. and it should be done in less than 5 minutes. Then regarding cosmetics, those with acidic pH such as soaps and shampoos, mild in nature should be used. It should be non-scented, and soaps and shampoos are not at all mandatory also. Next is regurgitation, or it is also known as post-setting, and it is the spitting out or vomiting out of curdled milk soon after the feeds. Okay, and it is insignificant if the baby is gaining weight adequately, then if there is no signs of sepsis. Okay, and the baby is passing urine 6 to 8 times per day. Okay. Also frequent stools. Okay, the frequency of stools actually increases during the transitional stool period. Okay, it happens due to the exaggerated gastrocolic reflex. Okay, so like how does the transitional stool uh, make its transition? It is black, that is meconium initially, then it becomes blackish green, then it becomes mustard yellow. Okay. Next thing is breast engorgement, okay, which can happen due to the effect of transplacentally transmitted hormones, okay, and this may secrete milk-like fluid, okay, and resolves spontaneously. And other common issues are diaper rashes, okay, in which there is redness, inflammation, excoriation of skin, maceration of skins, all by prolonged contact of stools and urine with the child's tender skin. Okay. Next is physiological jaundice, erythema toxicum neonatorum, neonatal pustular melanosis, epithelial inclusion cysts. Okay. Examples being milia, bones, nodules, and Epstein pearls. We'll see each of these one by one in the subsequent slides. Next is nevus simplex. Okay. Or much commonly known as stork bite, salmon patch, or angel kiss. Okay, also known as macular stain. Okay, so all these five terminologies you should be familiar with. Okay, don't get it confused. Okay, next, Mongolian spot or congenital dermal melanocytosis. So this is erythema toxicum neonatorum. Okay, erythema toxicum neonatorum. See this diffuse transient eruption composed of red macules. Okay, red macules with a central pinpoint whitish yellow papules and pustules on the second day of life onwards. Okay, and it usually disappears by 8 to 10 days, or rather second week of life. Okay, if we examine this, we will find that there is eosinophilic infiltrates are there, and this is the most common type of rash in newborn. Okay, seen over the chest, face, and abdomen. What is the thing on the right side? It is neonatal pustular melanosis. There are melanotic patches are there along with pustules. Okay, these appear at birth and they may have different lesions, maybe in different stages of evolution. And if we examine this, we'll see neutrophils. Okay, although if we culture the secretion, it will be sterile. Only reassurance is needed. It resolves in few weeks or few months. These are epithelial inclusion cysts. Okay, this is Epstein pearls. Okay, this epithelial inclusion cyst, when this is seen on over the hard palate, it is known as Epstein pearls. Okay, and when they are in the gingiva, it is known as bone nodules. Okay, okay, and when they are seen over the skin in the area of sebaceous hyperplasia, it is known as milia. This is congenital dermal sinus, okay, which may mark underlying neural tube defect. Okay, underlying neural tube defect may be there. And this is, which we mentioned in the previous slide, physiologic breast hypertrophy in a neonate can be seen in both male babies and female babies. Okay, there is the pattern is that symmetric enlargement of breasts in a neonate without erythema or tenderness or warmth. Okay, it happens due to the effect of maternal estrogen resolves on its own. We should not squeeze or press and let out any milk or milk-like secretions. It resolves on its own without any residual problems. Yes. So again, I tell you, Be familiar with the terminologies nevus simplex, salmon patch, stork bite, and angel kisses. Okay, these four are synonymous. Okay, these are present at birth. They are telangiectatic macules, most often seen at the nape of the neck. Okay, the nape of the neck and over the eyelids and forehead. Okay, no complications. These splotchy pink mark fades with babies advancing age. Okay. These are the erythematous patches. Okay. They involute and resolve by 1 to 2 years. And don't be confused with the word port wine stain. Okay. Which is also seen over the face and which is almost similar in color. But that is pathological. Okay. Nevus simplex, also known as salmon patch, also known as stork bite, also known as angel kisses. They are benign and fades away on its own. They are telangiectatic macules requiring no treatment. Parents can be reassured. This is congenital dermal melanocytosis, more popularly known as Mongolian spots. The name is a misnomer actually, but it is popularly known as Mongolian spots. Why it happens? Due to the entrapment of melanocytes in the dermis layer during migration from neural crest to the epidermis. It appears as gray-blue macules in the lumbosacral region as shown in the picture, and it is present from birth and it disappears spontaneously by early childhood. This is subconjunctival hemorrhage, another common finding, especially during stressful deliveries or traumatic deliveries. It is a benign finding. It resolves over days to weeks. The parents can be reassured. No other treatment is necessary. This is a hymenal tag, which is usually seen in female newborns, only seen in female newborns. It is a normal finding, but parents can be very anxious. Only reassurance is necessary. Next, few other problems are bleeding PV, breast engorgement, also mastitis neonatorum, which we already mentioned, neonatal acne, that is essentially milia only, and male babies will have physiological phimosis, that is normal till 1 year of age. This is cutis murmurata, or rather to be more specific, it is physiological cutis murmurata. Okay, this happens in response to cold stress and is resolved by giving warmth to the baby, providing warmth to the baby. Okay, it is a net-like violaceous pattern, usually visible over legs and abdomen and trunks. And next you should know regarding the normal vital signs for a newborn, because this is slightly, not slightly, significantly different from adults and children also. Okay. Now temperature, it is measured with a thermometer in the axilla and the range will be 36.5 to 37.5 degrees Celsius in an open crib. Okay. And respiratory rate of 35 the lower range and 60 the upper range. 35 to 60 breaths per minute, which should be counted over one full minute. Why? Because there can be a phenomenon known as periodic breathing in newborns. Okay. So it should be counted for full 1 minute. And heart rate, it should be 102 to 162 beats per minute. Okay. Sometimes the heart rate may decrease to 85 to 90 beats per minute in some term infants during sleep. Okay. In these infants, it can be reassuring to check and see that the heart rate increases when they're active and feeding and playing. Okay. That is important.
Now these scalp swellings, they mainly occur during delivery of the child, and it happens due to bleeding or edema, which happens into various locations within the scalp and the skull. So this is a figure which shows the different layers of the scalp and which shows the lesions which we have to know about. Okay, first is the caput succedaneum. As you can see from the figure, it happens in the subcutaneous plane, and then there is cephalohematoma, which is actually very important. And the cephalohematoma, it actually happens within the periosteum. Okay, and then there is subgaleal hemorrhage, which happens between the scalp aponeurosis and the periosteum. What do you need to know, or rather NEETpg? Okay, first thing you have to learn is caput succedaneum. It is a fairly common lesion, approximately 40% of newborns have, and it can happen due to prolonged labor, where the child's head is trapped in the birth canal for a prolonged period of time, and even after vacuum deliveries. And it happens in the subcutaneous plane, and the content is edema fluid. It is seen immediately after birth, and it is benign in nature, which usually requires no treatment, or rather requires no treatment, and starts disappearing within the first 48 to 72 hours of life. It is diffuse in nature. It crosses the suture lines. It is diffuse and crosses the suture lines, and no significant associations are there. Complications itself are rare, but still for exam purpose, secondary infection, necrosis, and an extremely rare sign, halo ring scalp skein. Okay, and it happens above the periosteum. Next is cephalohematoma, which is less common, and it happens after a forceps or vacuum delivery. It is seen over the occipito-parietal areas of the baby, and the content is blood. It is seen only after 24 hours of life, and it is mostly benign in nature. It can persist for 3 to 4 weeks, or even up to 6 weeks, and then resolves on its own. It does not cross the suture lines. Okay, it has well defined margins. Okay, so that is a characteristic feature of cephalohematoma. It is associated with newborn jaundice and sometimes linear fractures of the skull, complications being secondary infection, calcification, and rarely osteomyelitis. And it happens due to rupture of vessels beneath the periosteum. Next is subgaleal hemorrhage, which is a rather important upcoming topic which you should be aware about. It is a rare condition. It happens due to excessive traction on the scalp. It occurs below the subcutaneous plane. Content is blood without a doubt, and it happens immediately after delivery, or it can slowly enlarge, and it can progress over a period of days or hours, and it is a diffuse fluctuant swelling which carries a high rate of mortality, or it is fatal. Okay, it can be fatal. Okay, and the complications are shock, hypovolemia, and even death. Okay, and it happens due to trauma to the emissary veins between periosteum and the scalp aponeurosis. And if it is there, we have to treat by PRBC, IV fluids, and evacuation. And this is a figure, so that we should just go through the three conditions again. First is caput, it is there, and subgaleal hemorrhage between the aponeurosis and the periosteum, and cephalohematoma inside the periosteum, and caput succedaneum just beneath the subcutaneous plane.
So neonatal reflexes or primitive reflexes. They are also known as developmental reflexes. They are generally present at birth and they resolve usually over a set period of time. Okay, they appear and resolve in a fairly set period of time. These reflexes, they may reappear later in life due to the presence of some degenerative disorders. Okay, so why are these important? Why do human babies have these reflexes? They are mediated at the brainstem or spinal cord level. Okay, infants, they have certain reflexes that serve them well for attaining some functions for a brief period of time during their development, but then they are integrated by higher centers in the brain. Okay, meaning that they aren't used anymore. Okay, and they resolve in a fairly set time course with maturation of the descending inhibitory projections from the cerebral cortex to the subcortical motor system. Okay, so these are the common, or rather the more important neonatal primitive reflexes. First is a Moro reflex, then comes palmar grasp, plantar grasp, ATNR or asymmetric tonic neck reflex, stepping reflex, placing, Landau reflex, Garland's reflex, rooting, and the parachute reflex. Okay, so we'll go into each and just see when they appear, when they are gone, what is the function and how it is elicited. We'll see. So this is the, yes, it is obvious, it is Moro reflex. Okay, it is present starting from the 28th week of gestation to the, and it usually starts from 28 to 32 weeks of gestation, and by 37 weeks it is fully developed. Okay, and it is seen till 5 to 6 months postnatally. Okay, how it is elicited? It is elicited by the sudden dropping of the infant's head in relation to the trunk, which results in the abduction and extension of the infant's arms and opening of the hands by flexion. Okay. And absent Moro, it signifies CNS malformation or HIE stage 3. Unilateral Moro, it signifies either Erb's palsy, or that is brachial plexus injury, or some clavicle fracture or bone dislocation. Okay. Persistence of Moro reflex even after 6 months of age means either a cerebral palsy-like condition or immaturity of the brain. Next is palmar grasp reflex. Okay. It is usually seen from 28 weeks of gestation, fully developed by 32 weeks, and it is seen till 2 to 3 months postnatally. This is plantar grasp. This is important. Okay. It is seen from 32 weeks onwards to 6 to 9 months postnatally. Okay. The time where it disappears is a bit more variable. Okay. The plantar reflex is well established by 32 weeks, and it typically disappears by 6 to 9 months of age. During the normal plantar grasp, you see the direction of the stimulation. Okay, the toes plantar flex. Okay, the toes try to grasp the object that touches its sole. Okay, it seems to flex around the examiner's finger when it is brought across the ball of the foot. Okay, it is not towards the feet, it is downwards towards the ball of the foot. This is ATNR, or asymmetrical tonic neck reflex. It is seen in term babies from 37 weeks of age. It is fully developed by 1 month of age, and it is seen till 4 months postnatally. Okay. It is characterized by extension of the upper and lower extremities on the side to which the head is turned. Okay. With flexion of the contralateral upper extremity. Okay. Also known as fencing posture. Okay. For our purpose, it can be also be attributed to an archer's pose. Okay, okay. Just like an archer holds his position to actually fire an arrow. Okay, this is the position. Okay, that is somewhat similar to this fencing position also. It appears beginning at 35 weeks, well established by 1 month, and disappears by 3 to 4 months postnatally. Next is infantile stepping response. Okay, the stepping response can be obtained in infants greater than 32 weeks of gestation, elicited by holding the infant in a vertical position with his or her feet in contact with the flat surface. Okay, this initiates a slow alternate stepping action of flexion and extension of the legs. Okay, just as shown in this picture. Okay, this is a very beautiful reflex to elicitancy. Next is placing reflex. Okay. So as the word suggests, it is bringing the anterior aspect of the child's tibia against the edge of a table, or rather any surface. Okay. And the response being the child shifts or lifts its leg onto the table. Okay. Onto the table. And it appears at birth and disappears by 6 weeks. Now this is rooting or sucking reflex. Okay, stroking the infant's cheeks, and the infant turns the head to that side and makes sucking motions. Okay, it is usually seen in term babies, and it passes till 2 to 3 months postnatally. And finally, Gallant reflex, that is elicited by holding the child in ventral suspension or placed in prone position, and it is performed by running a finger down the paravertebral area of the child's back on one side. Okay, the response swinging of the pelvis to the stimulated side. Okay, that is Gallant's reflex. and it is seen in term babies and it persists till 2 months of age postnatally.